Okay, so today's my presentation is really for the long COVID, and then what may happen in ASD children, especially with a component of the inflammatory or neuroinflammation. And this is, I have nothing to disclose for conflict-wise, and the presented data it's an extension of my previous funding from Brain Foundation, O'Sullivan Foundation, Jonte Foundation, and DHS. And thank you for continuous funding all the works we are doing. So talking about the long COVID syndrome, which is quite new, we only know COVID for the past a little more than probably more than about 3 years, and we didn't realize, but many patients after suffering from the acute COVID-19, they are lingering symptoms, and this is not a chronic viral infection. So as shown in this slide, viral load is just acute stage, and most of the people virus is not going to stay here more than 4-5 weeks. So the end antibody is spiking. However, long COVID syndrome is really start several weeks after the acute stage. With WHO, most recent WHO definition of the long COVID, to my knowledge, they define for those symptoms starting within 12 weeks after the onset of the acute symptoms. And typically, I see those long COVID symptoms start like 3-4 weeks, but the times may vary. And this is, I copied from the one of the Frontiers Immunology. And this just simply showing when SARS-CoV activate with toll-like receptor or RIG1, then it's that generating a large amount of the type 1 interferon, which then go into the like a STAT1, STAT2, then for the oxyradicals. So it's really the burst immune activation. And the end result can go NF-kappa B pathway, but also for the inflammasome pathway. And it's like downstream cytokines often, downstream cytokine pathway is not like the, it's may including the IL-1 beta, but also, other type of the cytokines, typical inflammatory cytokine, TNF-alpha, IL-6, these are all included. So that is the reason why some of the early stage for severe patient, like a MIS-C or post-COVID cytokine storm, anti-IL-1, IL-6 receptor or anti-IL-1 beta, those cytokine-specific biologics has been used for controlling the post-COVID inflammation. And as you can see from the previous figure, type 1 interferon is a major role for initiating the cascade of inflammatory response of the COVID infection. And why it was, why we appreciate the use, the role of the type 1 interferon because of the several studies. And one thing is it's type 1 interferon is very crucial. So if we don't have it, we're going to be overwhelmed by COVID infection. But on the other hand, type 1 interferon production is too much that will causing the excessive. So balanced activation will be necessary. Then initially it was noticed, but like severe COVID infection was predominantly seen in the old age patient. It's usually above 65. Then Jean Casanova's group first shown that those patients who suffer from severe COVID infection, they do have the antibodies against the type 1 interferon. So those type 1 interferon autoantibodies appear to increase with age. So actually, one study shows about 20-25% of the older subject above 70, the 20-25% of the patients, they do have the type 1 interferon autoantibodies against the type 1 interferons. So this may be the probably when you are getting older, they may have the enough T cell or other immune memory. So they are trying to producing the autoantibody to controlling the excessive immune activation. But like COVID, there is no immune memory is present. Then I think the older people who may have the autoantibodies against the type 1 interferon have the severe infection because less combative to the initial immune reactions. And also the type 1 interferon is implicated with BCG type trend immunity, which means when it's activated, it will causing the very persistent epigenetic changes in innate immunity, which is causing the more pro-inflammatory type response, which is maybe seen like a measles virus influenza type. And that might be also some clue for the later identified long COVID type symptoms. And when immunology is thinking about for those infectious conditions, the primary immunodeficiency, which is very exaggerated, the condition of type 1 interferons action may provide us a clue. And when that COVID infection was starting, I really thought the severe cytokine storm reminds me that type 1 interferonopathies, which is a recently established primary immunodeficiency with very much overlapping feature of the long COVID. Essentially, the base of this group of the primary immunodeficiency is this was the excessive production of the type 1 interferons with sensing the viral RNA or DNA, then very significant, highly inflammatory conditions. And those, this is like last 2021 review paper I take. And there's a many gene mutation was implicated by type 1 interferonopathy. But if you see the latter part, when interferon is produced, then it's really the activation is STAT1, it's through the JAK1, and also type 2 is associated. So it's really the interferon pathway. And one thing I thought is interesting is essentially type 1 interferonopathy prototype is Aicardi-Gutierrez syndrome. This type of the patient is really characterized encephalopathy, then affected with the basal ganglion calcification. And it's really the affecting the cognitive functioning, but also some tremors and also like coagulopathy type symptoms. Those are somewhat overlapping long COVID. Then also the other type of the activation of the type 1 interferon production eventually will cause a polyclonal B cell activation, then autoimmune type condition. Then some of the inflammatory markers and several papers indicating for the autoimmune type, like one subset of the lupus, which is called the type 1 interferon signatures. Those type of the clinical pictures. They also seen some long COVID patient. So the one of the striking thing I thought interesting is the interferonopathy is any form of the type 1 interferonopathy, they always have the long neurological involvement. Essentially, they affect the brain. And it's really type 1 interferon. That's maybe not surprising because the type 1 interferon affects the microglial cells, then also the balance of the between clearance of the damaged tissues and excessive phagocytes. But on the other hand, like a type 1 interferon, if you use effectively, can be therapeutic. And so the bad effect of the type 1 interferon, at least for this type of the primary immunodeficiency, it's really shown to be like a developmental regression. So psychomotor retardation, seizures, and encephalitis type condition. So is a long COVID patient has a neuropsych symptoms. So this is like one of the paper I wrote because they did some meta-analysis. So then what kind of symptoms reported in the COVID, long COVID patient. So when you top of the graph, there's a lot of neuropsych symptoms like depression, anxiety, fatigue, cognitive dysfunction, probably so-called brain fog, and sleep disorder. Then also some small and respiratory cardiac. But it's a top, most common features essentially neuropsychiatric symptoms. So those conditions made me think, if this happened to the intellectually disabled children, especially like ASD children with difficult behaviors, it will be very complex and it's hard to recognize and maybe very challenging to treat. So this is for the possible mechanism of the neuropsychiatric symptoms in long COVID. This is, I copied from the Dr. Iwasaki's paper. Her group was published in Cell using the animal, rodent model of the long COVID. And the essentially the classified A, that is a part like her group as a postulate as a main cause of the neuropsych symptom. So essentially neuroinflammation, then affecting the neuronal and the glial cell functions. Then for the dysfunction. And other implicated condition is autoimmunity, then also the some of the reactivation or thrombotic event. Direct invasion of the virus to the brain, I think it's very rare and that it's not very well documented because of the nature of this virus, I think. So this is like one of the most recent published paper in the New England Journal of Medicine. It's 57 years old. Then it's really the post-COVID and severe delusions. So essentially this case was presented as a Cotard syndrome. This is a delusional misidentification syndrome, and also catatonia, depression. And this is a patient suffers from the grand seizures, then anti-seizure medication. And this patient has been treated with ssRNA because electrocution was offered but was declined. And but after this episode of the admission, she seemed to be, at least from that published paper, she continued to be suffer from significant symptoms requiring a repeated psychiatric admission, So she was pre-existing for depression, like futures. And I saw this patient. I'm sorry. I read this paper. Then I kind of like to compare the one patient I have experienced. So this is a one patient, 13 years boy, and it's really I started seeing this patient in the end of the 2021. And his initial exposure to the COVID, it's very beginning of the COVID pandemic, when all the family members got sick. And around that time, PCR wasn't available, so his infection was later confirmed by presence of the antibodies. So after that, he has a significant neuropsych symptom, but seems like further got worse when he given the COVID vaccine. But on the other hand, I wasn't sure if he has another COVID exposure. But his symptoms are very similar to the patient reported in the New England Journal of case. And he developed eventually catatonia, hallucination, and mutism, and also very, it's almost similar symptoms like the schizophrenia. And this is a patient who was completely normal and developing a typically very good student. Then he was, because that was 2020 and early 2021, long COVID wasn't very appreciated. So he underwent the autoimmune encephalitis workup, which is completely negative. But his condition continued to get worse. And by the time I was seeing him, he underwent 3 times psychiatric admission, and he was placed on the olanzapine high dose, which made him very sleepy and little depressed cognitive functioning. And because of all these extensive workup previously done, the other causes are pretty much ruled out. Then also we did some studies of the immune functioning that is indicating of the activation of the type 1 interferon signaling pathways. It was reasoned he may be benefited with immunomodulating agent targeting the colchicine and maybe other type of the immunomodulating agent. So he was started on the colchicine and then also added minocycline. And with this addition of the 2 immunomodulating agents, he was able to slowly taper off the olanzapine. Good thing for him is from September from this year, he was able to resume full-time school attendance. He still has a little bit minor flare-up with the sick contact, but at least unlike the patient present in the New England Journal of Medicine, he continued to attend the school full-time. Then also he's catching up with the schoolwork. He may still have the IEP and some accommodation necessary, but he making the good grade. That's what he says. Okay, so why the colchicine was selected in his case? Because colchicine was it's old medicine. It's relatively inexpensive, so easy to prescribe. But also more importantly, colchicine action was implicated with tubulin disruption and inhibition of the NALP3. So therefore, it's really blocking the downstream major pathway downstream of the type 1 interferon signaling pathways. Then some patients cannot stabilize the toilet colchicine well because of the GI side effect. And one of the reasons I thought the colchicine is well justified because of the new biosimilars, which is like a blocking the binding site of the tubulin of the cortisin. It's called the sabizabulin. It's really effective to controlling the cytokine storm type condition and severe. But these medications are not approved as yet. But I think this type of the medication works, probably long COVID for cortisin is likely works. That's my initial thought. Okay, so this is most recently published data for the oral zabizabrin's effect for the severe long COVID. These are adult patients. But as compared to placebo, it's really the striking reduction of the mortality. So it's really the, this type of the signaling activation in some stage of the COVID infection. It really have a role, then blocking this pathway, some patient may be benefited. So another case of the I have, this is also the typically developing patient. Then she started to have the neuropsychiatric symptom after suffering from COVID. And this is also the early case. She was known to have the COVID-19 in March 2020. And again, her COVID-19 was diagnosed because of the presence of SARS-CoV-2 nucleocapsid IgG antibodies. And so her case is really consistent with the COVID, long COVID. Her neuropsychiatric symptoms started after recovery, 3 to 4 weeks after recovering from COVID-19. And her neuropsychiatric symptoms are very significant, almost like tremor, severe insomnia, but also a lot of anxiety, psychosis type symptoms. And she was seen by psychiatrists and several different medications, which she didn't respond at all. So in this case, I thought this is so much like high anxiety and other. So I suspected maybe tryptophan metabolism affected. So this case, and she's already old, and so I don't have to worry about the tooth discoloration. Minocycline was started. And her case is very dramatically responded to minocycline. But the problem is in her case is I was unable to discontinue or tapering of minocycline. So she almost minocycline dependent. So in her case, she may have a little bit more genetic predisposition for. So what is the effect of the minocycline? So minocycline, it's really the well known to affect the microglia cell activation, essentially suppression of the neuroinflammation through suppressing the microglia cell activation. And also another well-known effects of the minocycline is blocking the idle pathway. So essentially, inflammatory cytokine like IL-1 beta activate the tryptophan, and then going to the its quinoline pathways markedly activated. So blocking that pathway may be helpful in some degree. It's a very complex pathway, then its a balance may be necessary, but some condition, especially it's best known, like a reperfusion injury caused by ischemia, minocycline has been well shown to have a good effect. Then also minocycline has been used for the skin inflammation or autoimmune condition like psoriasis. So this is like a tryptophan pathway, and it depends on the which metabolites giving their changes. But one of the reason is idle pathway is activated because the downstream idle pathway will eventually help the T cell to produce more regulatory T cells. So, but from that process, each process, there may be other toxic substance which may activate the neuroinflammation. So it's a very complex pathway. So this kind of the tryptophan metabolism is implicated with long COVID. So I looked for the literature search. And so this is a few papers actually reported, and they looked up the kinuranin, which is like increasing with the idle activation, and idle activation is implicated in inflammatory response when like iron beta is best known. So this is long COVID patient. There is a serum level of the increasing kinuranin. So some patient who has a high kinuranin serum or the like a production of the kinuranin of immune cells, they might be benefited by minocycline. So long COVID is a very complex pathway. Then what will happen and what do we need to see in ASD? I was afraid initially for long COVID and ASD is just this may just worsening pre-existing very difficult neuropsych symptoms. Then also maybe even seizure may be triggered. But this type of the change of the behavioral symptom may be just simply attributed just to being autistic. Then also some of the effective medication, which is and also inexpensive and easily accessible, like colchicine, their side effect of the GI symptoms. Then the ASD patient have a lot pre-existing GI symptoms often present. So there might be difficulty in treating these patients such easily accessible medications. So this is one case I had is an ASD subject, and she's also the similar like the case presented before, 18 years old, and he was initially like a autoimmune encephalitis type picture because he was diagnosed with ASD, but has a fairly stable condition until he has a grammar seizures, which is in 2017. But he has been doing okay. It's not like the patient who has a very fluctuating behavioral symptoms. However, he started having the significantly worsening like a encephalopathy type symptoms. And at that time, I wasn't really aware, but essentially he likely has a COVID-19 infection, like a very early January 2020. And at that time, whole family member got sick. So it's not clear when he got, but his exposure was later confirmed by antibody. Then unfortunately, all these AE work up as negative as expected. Then he went to the Lyme disease doctor, then treated with Lyme. I wasn't sure why, but he didn't respond at all. Then in March 2021, he has another COVID infection, which is PCR, and then it's usually he was treated as a monoclonal antibody. So acute stage COVID-19 was very mild. But 3-4 weeks later, it's significantly worsening. So at that time, I wasn't completely aware of the long COVID. So the mycophenolate was started more for the like a mild immunomodulating agent. But then again, in December 2021, she got another COVID-19. So, and that time I get more familiar with long COVID. So I started colchicine and some celecoxib showed like a pulsing. So he responded very well to colchicine, but he continued to have the minor flare-up. Then we have to give some colchicine a few weeks, maybe some addition. So this is like a case. He was really probably should have been treated for the long COVID from the beginning, but I wasn't very educated on how to treat it in the early state of the long COVID pandemic. And this is another patient as an ASD subject, and this patient he didn't really get sick with COVID until December 21, and he was already fully vaccinated, but never, and he was on the minocycline for acne, and actually I continued the minocycline a little longer because of the beneficial effects of the behavior symptoms as well. However, he was really few weeks after the acute COVID-19, he's worsening symptoms again. And I tried to just use celecoxib only, but it wasn't really controlled well. And minocycline and doxycycline a little excessive GI side effect. So I switched to intermittent colchicine and celecoxib. And again, he continued to have mild flare-up after -6, but he was much easier to control as compared to the previous case. So this is, I'm sorry, this is a case 4. And so this is a type of the contrast. So depends on how the immune system has some defense and how much immune activation occurs, maybe need for immunomodulating agent may change. So this is for the one of the like how the monocyte macrophage pathway is also affected by the COVID-19. This is a preliminary data. The number of the patient is not very high, but I have a few patients which I can categorize as a long COVID, like a group 1 ASD patient. Then number 2, group 2 is a ASD patient without long COVID. And group 3 is a non-ASD, but long COVID. Then the group 4 is just a simple ASD without long COVID. So this is, we just looked for the iron beta in response to zymosan and also the CL097. So those are all activating the pathways implicated with the type 1 interferon. So I was really stunned with long COVID, non-ASD long COVID, like a group 3, it was a much higher iron beta compared to the normal control. And this type of the difference, I can see that in the soluble TNF receptor 2, which is more reflecting a TNF alpha production. Then also, I never seen that very high IL-23 until COVID pandemic hit. And IL-23 implicated IL-17, IL-7, the Th17 cell activation. So, and some studies showing long COVID is associated with Th17 cell activation. So again, I see the high level of the IL-23 production in the non-ASD long COVID, but those are also varied. ASD children varies a lot, so it's probably more pre-existing condition is affecting. So the other type of the medications we can use for the long COVID, because like a type 1 interferon that's going through the JAK pathway, but also IL-23, IL-12, those like some of the activation, it's also going through the JAK1 type 2, then in the STAT1 pathway. So I have tried to use a JAK1 JAK3 inhibitor because that was commercially available. It's called the baristonib. And also the new medication, it's called the dual inhibitor of the type 2 JAK1. It's now testing for the psoriasis type patient and also for the IBD patient. So these medications I thought might be easier for ASD children because they don't have much GI side effect. And actually, they are tried on the IBD patient. So GI symptom may be benefited with these blockers. So as a conclusion, long COVID symptoms likely reflecting the very excessive imbalanced immune activation. And it's really affecting multiple pathways. Then as a result, therapeutic needs will vary, depends on the each subject, genetic predisposition, epigenetic changes. And controlling long COVID symptoms, it really needs a precision medicine. I don't think one medicine will control everything. So one size fits all type approach probably not applicable. And especially for the patient like pre-existing intellectual disability and neuropsych symptoms, it will be very problematic to use to control long COVID syndrome. And it's much more careful, individualized approach will be necessary. Then again, much more information necessary.